Thank you. It is a pleasure to be here with you to speak about this important topic. Oh yeah, that is really long. Okay, so anyway, I'm a radiation oncologist, and I'm a bioethicist and someone who's had a lifelong interest in patient-centered communication and has been very fortunate to work with many amazing advocates that I'm seeing all around this room. So I have tried to learn as much as I can and was incredibly excited about this Lancet Breast Cancer Commission that was led by Professor Charlotte Coles, who's here and who led a session right before this, and I know some of you already heard quite a bit about the Lancet Breast Cancer Commission, but what I want to highlight for those of you who weren't in the room is that, as Fatima Cardoso highlighted just a moment ago, not only was there a focus on a theme on the group of patients with metastatic breast cancer, there was also a theme that focused on communication, and these two themes really went hand in hand. And communication is so essential because we know that many patients will tell us that breast cancer is a condition that feels like it's taking your power away from you. And being able to regain that sense of power and control through your sense of autonomy to be able to control your decisions is incredibly important. And it is something that's probably the most fundamental obligation of every healthcare provider in this room. And so we talked about patient empowerment, which we defined as being fully informed and supported to confidently participate in decisions about personal health and well-being to your own desired extent. And patient-centered communication has to acknowledge the unique background and need for information of each individual, consider their situation holistically, and work with patients to define and achieve shared goals in care. As we just heard, patients don't fail, but we do fail to prevent the development of metastatic disease for many. And so outcomes of metastatic cancer have actually improved considerably in the past decade. As we've learned, the median overall survival has remained about 2 to 3 years for decades, but within the past 5 years, the median overall survival has reached 5 years for 2 out of the 3 main subtypes of disease, which do account for the majority of the population diagnosed. And we have many long-term survivors who live 10 years or much longer with metastatic disease, and so some subgroups are being considered as people with a chronic disease. And so given this spectrum of disease that we have, both at a molecular level and in terms of disease burden, we need to focus on communicating in a personalized way because there's some patients who have potentially curable oligometastatic disease. Many patients will have long-term remissions or stabilizations, and then there are many patients with more rapidly progressive disease of the triple-negative subtype frequently, where their unique needs are also important to tailor our communication to address. And so management and communication must be individualized, not just on the basis of tumor biology, but also based on characteristics of the patients, including their own values. And so there are challenging conversations to be had here. There are conversations about the balance between efficacy and toxicity of treatments, between the focus on survival, quality of life, and relief of serious health-related suffering. It's delicate, it's personal, particularly in the setting of metastatic disease. As we've heard, supportive care and palliative care are crucial parts of the management of all stages of disease, but in particular metastatic breast cancer, and should be incorporated from its diagnosis. There was a survey that showed that only 17% of U.S. oncologists surveyed said that they refer patients to palliative care upon diagnosis of metastatic disease, despite 2/3 of those same respondents agreeing that earlier introduction of palliative care leads to better outcomes. We know that there's also resistance from patients and their families, often due to stigma and the perception that palliative care means only end-of-life care, which of course it does not. So what we have to accomplish as providers is a lot of things. We've got to be able to explain that metastatic disease is usually incurable, but is treatable and can be controlled for many years. We have to explain that treatment aims to slow cancer progression, reduce symptoms, improve quality of life, and prolong survival. We have to understand how the patient prioritizes longevity, comfort, and independence. and then help patients apply those values to make the treatment decisions that are best for them. It's not one size fits all, and it requires the patient to understand those goals, logistics, and side effects of treatment, and for the clinician to understand the patient's individual preferences, values, and life goals, right? Someone might want to attend a wedding, travel, meet a grandchild, avoid a change in appearance. We need to hear that, and we need to be able to elicit that information. We have to give realistic hopes and expectations. This is incredibly challenging, but also essential. Patients do want prognostic information sometimes, and they may not ask for it, but others don't want that information. And so it's up to the providers to ask if, when, and how patients want to talk about prognosis. It's best not to confront patients with information they don't want. I mean, that seems like hit you over the head obvious, but it's worth saying. And many patients do find it helpful to know the truth. There's actually no evidence that information about prognosis is harmful to patients or that it increases anxiety or distress when it's done in a patient-centered fashion. For patients who want quantitative information on life expectancy, providing ranges, like worst case, typical, best case scenarios is helpful. It conveys more hope than a single point estimate of median survival. And actually, the speaker right after me is the world expert on this, so I'm going to leave it to her to explain more about that research. There are principles and best practices for providers to build rapport, convey respect by setting the agenda and specifically asking about patient priorities, share information, check understanding, empathize, review, and make recommendations. How many of you have been in a healthcare interaction where you've walked away with only like one thing you remember? And even when you bring someone with you to take notes, and it can be highly educated people. I'm a physician. I walk away from those visits and I have missed so much. And so, as you've mentioned, sometimes recording things or it can be something that helps with that. And you need to come to a mutual understanding about next steps. Here's just some examples of language that can be used. With these are provided by experts that I know in health communications and expert clinicians that I aspire to be like. And so with these recent tests, we have some new information about the disease that I'd like to discuss with you. Unfortunately, the cancer has spread too. We can talk through what this means and what the options there are. I know this is hard to hear. I'm here to support you. We'll work with you and your other doctors to get a plan in place that works best for you and your priorities, centering the patient. Here's what we know so far about this cancer. Sometimes the hardest thing is knowing you have metastatic cancer and not yet knowing what your next steps will be. Once you have a plan and you understand how to put that plan into action with your team, I really do think it'll feel so much better. Here are the options for how we might treat this. After presenting the options, what's your understanding of what we've discussed so far? Is there anything else I should know about you that'll help me take the best possible care of you? Based on everything we've discussed, I think this would be the best option for you, but does that sound like the right path to you? Again, centering the patient, you. So there's one last complicating factor that I want to mention because there's a lot of people in this room who I think could actually help with something that really is affecting a lot of human beings in this country and abroad. In the US, we actually have the 21st Century Cures Act that prohibits information blocking from the electronic medical record. How many of you know what I'm talking about here? This is a big deal, right? So you get a little alert that says, you've got mail. You've got something in your patient portal. Now, you may get a warning that says, this may be something distressing, so you may not want to check it till tomorrow, okay? And this comes for radiology results, pathology results. Who doesn't check that email when it comes through? And I will tell you that just 2 months ago, a friend of mine, whom I saw once in a clinic visit, never needed radiation, never treated her, but a friend of mine found out through a "you've got mail" message at 10:30 p.m. at night. That's when the radiologist read the scan and released the results, and she'd been having some arm symptoms that were improving with physical therapy and actually almost didn't even go get the brain scan. Wasn't expecting anything, so opened it up at 10:30 at night and had new diagnosis of metastatic disease, first sight of metastatic disease to the brain. And the only person she could reach at 10:30 at night was her friend, the radiation oncologist. Thank goodness, right? So I called her back, and we had a 2-hour conversation about everything that one wishes to have a conversation about. She's like, should I start writing my journals to my daughter now? That was the conversation we had. The way she experienced that disclosure of her diagnosis was wrong. And I went both to that institution, which is where I was on faculty for 16 years and was the director of the Center for Bioethics, and my own institution now, and said, we've got to fix this. I can't believe this happens. And apparently, although it is by no stretch of the imagination patient-centered or ethical, apparently, most hospital lawyers are going to tell you it's legally mandatory. So this is a room full of people who can make that difference. So we need to fix this because patients should not be traumatized in this way. There's ongoing work. We heard in the prior session about the need for tools. There is much work that's being done by experts in communication and decision science, including my colleague Sarah Hawley at the University of Michigan, looking at how to develop accessible tools. And so we're actually using my Komen Senior Scholar Grant to model on a grant on a tool she created for the early stage decision making setting. And I want to call out Sarah Rohini and Jane Mizell, who are my collaborators in that work and who gave me a lot of the language for the slide that had good language. And I want to close with a quote from a patient. Above all, what matters is not to lose the joy of living in the fear of dying. I want to acknowledge the many people who contributed to the work of the Lancet Breast Cancer Commission on communication, particularly Professor Coles, who chaired it, and the junior investigator, Marika Thompson, who really did so much work on this particular theme of communication and empowerment. Thank you very much.